Good morning, everybody. Well, at least it's my morning. Not sure when you're watching this. Just kind of like I started off the last video. But welcome back. Hope everybody's doing well. This is going to be your chapter 13 video. It doesn't have chapter 13 up there because I didn't like chapter 13's PowerPoint. So I'm going to do my own overview of pharmacology video. This will probably have some principles that we've already covered, but it's just super important information to help you be successful in pharmacology. So let's talk about metabolism and something called biotransformation. Some medications are active immediately after administration, and they become inactive as they metabolize. The other drugs must be metabolized from the inactive form in which they are administered to the active form. This process of the chemical actually changing a medication through metabolism is just that. It is biotransformation. It's important to understand when we talk about therapeutic index, larger equals safer. And that is important because basically when we're talking about a therapeutic index, it's the ratio of the medication that's lethal in 50% of the population. And then they look at the dose that is effective in 50% of the population. So drugs that have a greater difference between the therapeutic and lethal doses, they have a wide therapeutic index, and those are considered to be safe to administer than those with a smaller or a different, I guess what it's basically that, a smaller difference between the effective and lethal dose. Medications, when we're talking about medications in which the lethal and therapeutic doses are very close together, they have a narrow therapeutic index, and those are the ones that are dangerous. They could be lethal. And so let me give you an example of a drug that has a super narrow therapeutic index, meaning it's very lethal, and that would be digoxin. And digoxin is used in treating patients with heart failure and atrial fib. It increases the cardiac contractility, so it makes the heart pump harder, stronger. And the way it does that, it inhibits the sodium-potassium pump. And it leads to increase in intracellular calcium. But the therapeutic range, so the dose, right, is 0.5 to 2.0 milliliters. And so that's very, very narrow. A toxic range that could be lethal is anything above 2.5 mLs. So that's pretty narrow, right? And so that's the reason why people don't like to give that drug too much. But they do give it. I just got to be careful. They'll do something called a digoxin level for a lab to see where patients are at. And so that's an example of that. So remember the drug elimination, your liver does most of the metabolism part of the drug, but when we talk about eliminating the drug out of the body, that's going to be primarily through urine. Remember the definition of diffusion, high to low concentration, right? We're moving from a high to a low concentration. That is diffusion. But let's talk about first pass metabolism. And so basically what they mean by this is they're talking, again, just what I mentioned earlier about the liver and how it changes many of the drugs in the first pass metabolism before they can enter systemic circulation, where they can have their effect on their target tissue. Some drugs, such as benzos, like Valium. They're given in an inactive form that's active upon the first pass metabolism. So once it goes in to the GI tract, it's processed to the liver. Then you have that biotransformation, right, that we were talking about earlier. And that's what first pass is about. Affinity. So let's talk about affinity. And so when we look at the definition of pharmacodynamics, also called mechanisms of action, is the way in which specific medications achieve their desired effect. Most drugs have their effects by binding with cellular receptors. Receptor site theory, so it's a theory, states that there are specific receptor sites on cells. When those sites are activated by substances that have an affinity for that particular type of receptor, they inhibit or enhance the function of the cell. So that's how they make drugs. They make drugs for that drug to have that affinity to a certain cell receptor so that it can go in, make its way into the cell, and then cause the change that you're looking for, or that mechanism of action that you're looking for. All right, let's talk about this. Hypotonic solutions. You really need to know the difference between isotonic and hypotonic. So let's talk about it. Hypotonic solution, D5W, is a hypotonic solution. D5 is combined with dextrose and water. It's considered, again, a hypotonic concentration that will not remain in the vascular space. So it reduces the danger of fluid overload. Okay, so that's a good thing if that's what you're looking for, right? You wouldn't want this for like a trauma patient. You wouldn't want this for somebody you're trying to provide like a traumatic patient that you're trying to give fluid to as a replacement. This is not the one you want, but it has contraindications. So D5W should not be used for patients who require IV fluid replacement, just like I talked about, or in patients who are hyperglycemic. So patients who have high blood sugar, we wouldn't want to do that. But just to let you know, D5W alone won't actually help. I guess it helps, but it won't resolve someone who is hypoglycemic, right? It won't do that. You don't want to use this in patients who have traumatic brain injuries or stroke. Okay, so the reason why is you don't want that increase in intracranial pressure from the fluid moving into the cell, if that makes sense. And I don't want to get too technical, and I don't want to get too much in the weeds here. I don't want you to get confused between what D5W is as a hypotonic solution, right? But it can become isotonic once that D5, the sugar, is used for metabolism. And so, but again, I don't want to confuse you. Is this a hypotonic solution? But that leaves behind, if it becomes isotonic after the D5 is used, it leaves behind free water, which moves into the cell, including brain cells, and that causes cellular swelling or cellular edema. So, by me trying to explain why you don't give it to head injury patients could possibly confuse somebody, and I don't want to do that. So just remember, hypotonic solution, D5W, it doesn't hang out in the vascular space. However, it moves into the cell. All right. Let's talk about IV boluses for DKA. Your preferred choice of fluids here is normal saline. It is not lactated ringers. And I think your book kind of hints at lactated ringers, but it's not. It just simply is not. And the reason Well, let's talk about lactated ringers being an isotonic solution first. That's an isotonic crystalloid solution. Its indications are for significant burns and patients who are hypovolemic, right? So they have a volume loss. LR, the reason why it's kind of good is LR contains sodium, potassium, calcium, and lactate, and makes it more physiologically balanced compared to normal saline, which only has sodium chloride. This it helps maintain electrolyte balance in your burn patients, right? So some of your burn patients are becoming hypokalemic. They're losing potassium, and LR's got it. LR helps with all of those electrolytes that the body loses with fluid shifts in burn patients, or the patient who's losing lots of volume. They're also losing the electrolytes that go with that. And so why it's not good for your DKA patient is for the exact reason I just said, because it has potassium in it. And these patients who are DKA are challenged by electrolyte problems. Hang on, let me look at my notes real quick. So yeah, a lot of your DKA patients can be hyperkalemic, meaning they have too much potassium. And that's not always the case, but it's a large majority of these patients are either hypokalemic or hyperkalemic, and we can't tell that in the field. We don't know in the field if they're hyperkalemic. And so that's the reason why we stray away from the LR for these patients. So the lactate in the LR is metabolized by the liver, and it's metabolized into bicarbonate, right? So that helps to control some of the metabolic acidosis is a common concern in your burn patients. The LR, the electrolyte composition of LR, closely resembles the extracellular fluid, improving fluid retention in the intravascular space, which is critical for your burn shock resuscitation. However, lactated ringers should be used with caution in patients with liver failure. And since that lactate metabolism occurs in the liver, and those with hyperkalemia, like I just mentioned earlier, due to its potassium content. Normal saline is the best fluid, again, for DKA, for the opposite reasons of LR. DKA patients, they tend to be hyperkalemic, and they do not need the extra potassium that LR provides. LR contains lactate, again, and I just said this earlier, but I'll say it again, which is converted into bicarbonate. DKA patients are already undergoing acid-base corrections, and additional lactate metabolism may not be ideal. And so that is why we are going to go with the normal saline for your DKA patients. Pediatric dehydration, and this kind of works for adults too as well. It works out great because if you have someone who is hypovolemic and they require a fluid bolus, your dose for a fluid bolus will be 20 milliliters per kilogram. And so what you're going to do is you're going to take the body's weight in pounds, so say 180, and you can, if you want the exact accurate, you can divide that by 2.2. So in the field, what do? Well, normally we divide it by 2. And so 180 divided by 2 is 90. Right. And so we would go with 20 milliliters per kilogram. So then you would take 20 and multiply that by 90. And that will give you your fluid bolus. But that works for adults and peds. And let's talk about the IV drip formula. Let's talk about that. So there three must-haves to calculate an IV rate. You need a volume, a tubing setting, and a time, right? And so what it comes down to is volume in cc's or milliliters multiplied by tubing set and divided by total time in minutes. So let me get a scenario up here that we can go over. We can look at. Just a second. Now let me see if I can get a pen up here so I can write. I just want to see if I can write with this pen. Oh, I can. All right, good. Good. Let me erase that. Get the pen back up. Boom. All right. So if you had a question that read maybe something like, which of the following would be the proper drip rate for a 10 cc per kilogram infusion of a 4 kilogram neonate using a 15 drop set over 15-minute time frame? Let's look at that. So let's look at that and figure out what we're going to have to do first. So which of the following would be proper drip rate for 10 cc per kilogram? So they already give us the information here that we need. It tells us that we have a neonate patient and they weigh 4 kilograms. Okay. So a 10 cc infusion per kilogram. So that's pretty easy. 10 cc's or milliliters, right? And we're going to multiply that by the patient's weight, which is 4. And that gives us 40, right? 40 milliliters per kilogram. So volume here is going to be 40 cc's per kilogram. Our tubing set, and it tells us that we're using a 15 drop set. All right. And it wants us to give this over 15 minutes. All right, we can do this. We can do this. It's not a problem. It's not a problem. All right, so let's do the math here. 40 times 15. Is 600. Oh, sorry, I took the calculator off there. I'm just going to put 600 right here. 600. Oh, man, that was nice. Hang on a second. Let me erase that. All right. Stand by. 600. All right, and we're going to divide that by 15. Let's bring the calculator back over. Let's divide 600 by 15. And that's going to give us a total of 40 drops per minute. So that's going to be a total of my God, y'all. 40 drops per minute. That's how you do that. It's not hard. It's not hard. That's not hard. So that's going to be your formula. You're going to need to know that. Okay. You need to know its volumes and cc's, right? And so remember, the first thing you have to do, if they give you a weight like 180 pounds, you're going to have to calculate that into kilograms. And then you're going to take it by kilograms, multiply that by your fluid. That's going to, then you're going to take that, multiply it by your drop set, divide it by your total time. There you have it. All right. Epi is a sympathomimetic, right? And so you need to understand what that terminology means. It means it imitates the sympathetic nervous system. It stimulates the adrenergic receptors. We need to remember that albuterol is a beta 2 agonist. And so what that means, remember, you have beta 1, beta 2, beta 1, one heart, beta 2, two lungs, right? And so beta 2 is going to cause that smooth muscle in the bronchioles to dilate. And that's what it does. Let's talk about NSAIDs, non-steroidal anti-inflammatory drugs. All right, so what is an NSAID? Well, you know, an example of an NSAID here is ibuprofen, aspirin, so Toradol. All right, and so how do they work? Well, they work by inhibiting psychogenesis by the COX-1 and 2 enzymes. That's not, too important to really know, but that's how it works. And so by that, when those when those enzymes are inhibited, that decreases prostaglandin production. And when that happens, you get to reduce pain and inflammation and reduce fever. Aspirin is unique in this, is that it also acts on antiplatelet. It's an antiplatelet agent preventing clot formation. And so we know that it does that by being a platelet aggregator, stopping those platelets from ganging up on what they perceive to be as a clot, or not a clot, but they perceive to be a problem with the vessel. So what's the indications for use? Well, mild to moderate pain, musculoskeletal injuries, inflammation reduction, like from sprains or strains, fever control in certain cases. Now we use aspirin. You can use aspirin for pain all you want, but that's not why we use aspirin, right? We use it for cardiac related chest pain that we suspect the patient's having an MI, right, to reduce platelet aggregation. We don't use that for pain. You just don't. Now, you may take some aspirin at home for a headache, fine, but that's not why we use aspirin. And that's why what you'll have, you'll have an option. Let me get a drink of coffee here. You have an option now. You can use Toradol for pain and not aspirin, not even think about aspirin for that. So let's talk about the contraindications of NSAIDs. So GI bleeding or ulcers. NSAIDs can irritate the stomach lining and increase the bleeding risk. I can't take NSAIDs myself. It absolutely will cause my stomach to just come out of my body. I guess I got some ulcers there, and so I cannot take aspirin. I can't take naproxen. I can take Toradol, like as an IM injection. I just can't introduce it into the GI tract. So anybody with an increased bleeding risk, kidney disease, NSAIDs reduce renal blood flow, and that worsens kidney function. Some patients have allergies to NSAIDs, like myself. I don't have an anaphylactic allergy, but I have an allergy to it. Some patients may have anaphylactic reactions to this. Patients who are pregnant in their third trimester, NSAIDs can cause complications. So you don't need to be giving Toradol to patients who are pregnant, especially pregnant patients in their third trimester. Bleeding disorders, again, or patients on anticoagulants. It increases the bleeding risk. So adverse effects of this drug, I suffer the adverse effects. GI upset, ulcers, or bleeding. Consider if the patient has a history of ulcers, before you give it, consider it. And consider the increased bleeding risk. So be cautious in trauma patients. So let's say we have a patient in a motor vehicle collision and you suspect that they have a femur fracture. We're not going to give them Toradol, right? Because the mechanism of this accident was bad enough to cause a femur fracture. We don't need to be slamming Toradol, increasing a bleeding risk, right? Don't need to do it. Patients with renal insufficiencies or dehydration, we're not going to give them Toradol. So you have your dialysis patient who is having pain. We're not giving them any Toradol. Let's talk about aspirin toxicity. Since we mentioned aspirin as an NSAID, overdose can cause tinnitus. Do y'all remember what tinnitus is? You're a smart group. I bet you do. Ringing in the ears. Metabolic acidosis, right? So aspirin can cause that. It can cause hyperventilation with Rice syndrome. And aspirin was on its way out the door. Tylenol was a much safer drug than aspirin, did everything that aspirin could do. And people were not taking aspirin because of the Rice syndrome. Children, especially, they would have this because the Rice syndrome thing. It would cause problems with the pediatrics liver and could lead to brain swelling if they had this. So, aspirin was like what we had to take for a long time, and that's all that was around until Tylenol came out. And so aspirin was on its way out the door until they done the study and found that it saved so many lives of patients suffering a ST elevated MI. It very quickly reduces that platelet aggregation, actually opening up that cardiac vessel almost immediately and allowing blood flow back to the heart muscle. So yeah, it was on its way out the door. And so now it has a different purpose, and it is back, and it's back strong. So don't ever count yourself out. You never know. You never know when something as great as aspirin turned out to be for us. So the dosage of aspirin, 324 milligrams, it's PO'd, and guess what? It's chewed. In order to get, and that's that biotransformation again, if you swallow that aspirin, yeah, you get some of the benefit of it, but you don't get all of the benefit. It's when that 324 of aspirin is mixed with saliva, you get, by chewing those pills, you get the full benefit of aspirin. So it needs to be chewed. Ibuprofen or Toradol, again, those, I don't know if I mentioned ibuprofen before, but it's also an NSAID. Can be used for pain relief as well, like we talked about, except we're not going to give it to patients involved with acute trauma. Patients suffering from dehydration or bleeding risk should not receive any type of NSAID. All right, so I think that is all for the NSAIDs. Let's talk about nitroglycerin. Nitroglycerin, if you look it up in a PDR, a physician's desk reference, you will read it says it's not just a vasodilator, it's a potent vasodilator. Potent vasodilator. And so it's a wonderful drug that we need to respect for its vasodilation properties. Always remember to wear gloves when giving nitroglycerin, because it can rapidly absorb in the skin. So if you have the nitroglycerin tabs, always make sure you have gloves on. People I know in EMS back in the day allegedly used to take nitroglycerin tabs and drop it into people's boots, and they would put their boot on after to run a call, and they would be like, I don't know why I'm so dizzy. Oh my God, I feel like I'm going to pass out. That's how quick and how easily it can be absorbed, right? So be careful when you're handling nitroglycerin. Let's talk about chronotropic effect. Chronotropic effect is a positive increase in the heart rate. And so we usually call it either positive chronotropic effect or a negative chronotropic effect. So the negative would be a decrease in heart rate. Don't confuse chronotropic with inotropic effects. So when we talk about inotropic effects, we're talking about an increase in the force of the contraction. That would be a positive chronotropic effect, versus the negative inotropic effect being a decrease in cardiac contractions. An example of a inotropic effect would be a potassium channel blocker. I'm sorry. That would be an example of a positive inotropic effect. That would increase the force of the contraction. Calcium channel blockers can cause a negative inotropic effect, just so you can have an example of what I'm talking about. Medication administration route. So your fastest route, the body, you're going to get your fastest response from any drug that you give IV. Your IM injections would be slower. The slowest would be a sub-Q injection. Your IM injection is going to be, quite a bit. It's going to definitely be a lot slower than an IV injection, because you're going into the muscle itself. But think about sub-Q, you're barely going into the skin and dropping off drugs. So it's got to go through all the layers of the skin before it gets to the muscle. Epinephrine, that's going to be given for anaphylaxis, obviously, but you got to remember what the concentration of epi is. So if we're using epi for anaphylaxis, we're giving it 1 per 1,000, right? The kind of epi you give for patients in cardiac arrest that go IV is a mixture of a ratio of 1 to 10,000. So it's quite a bit of difference. 1,000 is a lot more potent. And so that means always you got to make sure that, one, we don't give people that have a pulse epi IV. I say that. I mean, you can give something called push dose epi, but you got to do it right. You're going to take 1 milliliter of 1 to 10,000 and mix it with 10 more liters of fluid. And so we do that, but we don't give straight epi IV. It has to be super, super diluted before we do that, right? So yeah, just remember that 1 to 1,000 is your concentration of epi. Enteral route. So enteral route is pertaining to the gastrointestinal system. And some drugs are affected by, remember, that first pass metabolism that I talked about when given internally through the GI tract. So drugs given internally are absorbed into the hepatic portal circulation. That's how it gets into the liver, and they're acted upon by the liver before entering the systemic circulation. So that's how that works, right? It needs to go. If you're getting something PO by mouth, you're gonna be affected by the first pass metabolism. It's gonna enter the liver, and then it's going to go through its metabolism change. And that's what's going to happen. So that's why certain drugs work going GI, certain don't. If you try to give nitro PO, well, it's not going to work because the nitroglycerin will be inactivated by the liver. Hope that makes sense. That's why nitro has to be given sublingually under the tongue. Let's look here. Aseptic vena puncture, friction with alcohol wipe. And so when you're doing IVs, and we just done those in the lab, and you're using your alcohol prep to provide an aseptic technique, use that friction with that alcohol wipe. One, yes, it's for the aseptic value, but the other value is it aggravates that vein and helps that vein to pop up a little more for you so you can get a good stick in. This is the site for your IM injections. We'll do this in the lab next week. Obviously, we won't be doing them on each other. But this would be the dorsogluteal site. It's just right here. It's below the hip. It's kind of basically the butt cheek side of this. And that's what they're showing there. This is the ventrogluteal site right here. You can use your deltoid in the shoulder as well, but if you're giving over 2 milliliters of fluid, we recommend going to the dorsogluteal site or the ventrogluteal site. Contradiction for so if you were to give a drug rectally, suppository, because Tylenol comes in suppositories. Right. And I don't know if any of you guys are going to work in an emergency department part-time after you become an AEMT, but you need to, this certification now will open up a lot of doors for you. And a lot of folks, even for paramedics nowadays, completely skip working in the pre-hospital setting. They just go straight to the hospital to work. National Registry's numbers for paramedicine is growing, and people are complaining, saying, well, we're still short, people. How can you show that you're graduating more paramedics through certifications, but we're not seeing it in the pre-hospital setting? Well, the reason why that is because they're not coming to us. Hospitals now see the value of hiring AEMTs and paramedics to work in the emergency department, and they're loving it. And so they're hiring that skill set. And some of these people never make it out there. Plus, there's opportunities. Once you become after an AEMT, maybe decide to become a paramedic, you can take an abbreviated RN course. It's a paramedic to RN bridge program, and cut off, 2 years of education. So yeah. That's why and so that's why the curriculum has to change, because we realize that not all people that are getting these certifications are just limited pre-hospital care. And so hemorrhoids would be a contraindication to giving anything rectally, any drug rectally. Neonatal hypoglycemia, we're not going to give D50. However, D10 IV is the appropriate drug for that patient. And we will probably, since nowadays we already have it mixed, it's no big deal. You used to have to mix it. Ingested poisons, activated charcoal is still, it's in your scope of practice as an EMT, and it's still out there. It's not in our neck of the woods. We don't like activated charcoal here, and at least in probably most of the metro Atlanta area, but it's still out there. It's still in certain areas, and it's still part of the scope of practice for EMT and AEMT. So we mention it. You'll probably see it again on an exam. Just remember ingested poisons, activated charcoal. And then the dose for epi for anaphylaxis. We mentioned it's a 1/1000 concentration. It's 0.3 milligrams, and you're going to give that intramuscular. So let's talk about the preferred IV site, the radial vein. Remember, I mentioned it. I call it the internus vein because even an intern can hit it. It's that vein that goes along your right beside your radial on your medial aspect. So that's where that is. We will do IO placements, and I will show you that the proximal tibia is the preferred IO placement for your pediatric patients. We need to talk about pyrogenic reaction. So pyrogenic reaction is a febrile fever response caused by the presence of pyrogens. That's a fever-inducing substance in the bloodstream. And it's often due to contaminated IV fluids or possibly equipment. The key features of a pyrogenic reaction, the onset usually occurs within the first 30 minutes of starting an IV infusion. Symptoms are usually sudden onset of fever and chills, nausea, vomiting, a backache or headache, or in really severe cases, hypotension. And so what do you do if you see this? I will tell you that in 25, 30 years of doing this, I've never seen it. It's more, you can have these with blood products, and they're a lot more, I guess they're a lot more common in blood products, but even hanging blood, I don't think I've ever seen it. But the immediate thing to do is just stop the IV infusion if you suspect a pyrogenic reaction. Monitor vital signs, and you would want to administer fluids and supportive care. So try to figure out, you've got some bad IV fluids, discard of them, hang some new fluids if you need to. The correct dosage formula, volume on hand, time desired dose divided by dose on hand. So let me do that one real quick. Let's do it real quick. I have to come up with something here. All right, so let's say I have an order to give 8 milligrams of morphine. Okay, I currently carry morphine in 10 milligrams per, we'll call it 2 milliliters. We'll see how this works out. Right, so the volume on hand for the drug, I have, actually, you know what? Let me change it. I just want to make it easy for you guys. It's easy as possible anyway. I have 10 milligrams, and I will just say I have 10 milliliters. So inside 10 milliliters, I have 10 milligrams. That's what the vial, that even look right here. So in this vial that I have, it holds 10 milligrams and it has 10 milliliters in that. And that, I'm just a little bit. too anal not to change that to make it look right. And this pen's not the best. 10 mLs. All right. So let's see here what our volume on hand is. The volume that we have is 10 mLs, right? And the desired dose here is 8 milligrams. And the dosage on hand you know what? That's right. And the dosage on hand is 10 milligrams. All right. Let's do the math. 10 times 8 is 80. And we're going to divide that by 10. So milliliters per milligram. And we have down here the dosage on hand is milligrams. So we're going to cancel these milligrams out. We don't need them anymore. 10 divided by 8 is 8 milliliters. So out of that vial, I need to give 8 milliliters to equal the 8 milligrams. And so basically what that means is there's 1 milligram per milliliter in that bottle. All right. That is that. Okay. I think that is all for this slideshow. Let me make sure. Yep, that's it. So I hope everybody got something out of this. This will be, again, this is the last video for the pharmacology section. I look forward to seeing you guys in the lab so that we can get all of our labs done and start doing scenarios and start slinging some drugs and treating some patients. Look forward to seeing everybody very soon.